Welcome everyone to Chapter 18, Concepts of Care for Patients with Cancer. Cancer's not just one disease, it's really a problem of cells growing out of control. So this entire unit can be simplified really in about three big questions. How does it form? How do we treat it? And what complications kill patients quickly? So cancer is basically when the body loses control of cell growth. What makes this hard is that treatments kill cancer cells, but they also harm normal, fast-growing cells like hair follicles, bone marrow, and the GI lining. Have rules for when to divide, when to stop dividing, and when to die. So cancer cells break pretty much these rules. So as far as immunity, normally the immune system can detect abnormal cells and destroy them, but cancer survives by hiding from immune cells. Clotting, cancer increases a clot risk because tumors release inflammatory chemicals. That's why cancer patients have an increased risk for the deep vein thrombosis and pulmonary embolisms. Sensory perception, chemo can damage nerves. Patients may develop neuropathy like tingling, numbness, and burning in their hands and feet. So when you hear cancer, think of cell growth disorder plus immune weakness plus clotting danger plus nerve problems. So all four of these concepts explain most of the symptoms and the complications. Cellular regulation, the body has a built-in system to control cell growth, and cancer occurs when mutation damage the control system. So all cancer cells were once normal cells. So cancer is basically a normal cell that's lost its brakes, and the accelerator still works, but the brakes are gone. You can take a look at this slide, normal cells versus cancer cells. Normal cells have the small nuclei, they're organized, clear boundaries, and uniform. Cancer cells, large irregular nuclei, disorganized, abnormal shape, and they grow rapidly and uncontrollably. So when a pathology report says abnormal nuclei or poor differentiation, it means malignancy is probably likely. Again, you can take a look at this comparison of normal and abnormal cells, benign versus malignant. Benign grows locally, slow, well-defined, and doesn't invade. Malignant grows rapidly, invades tissue, spreads, metastasizes, poorly defined boundaries, like we just talked about. But just take a look at your slide. Cancer development. This is kind of like a cancer timeline. So in the beginning, initiation, the DNA mutation happens, and it can be caused by carcinogens like smoking, radiation, or viruses. Then moves to promotion. Mutated cells begin multiplying, often linked to lifestyle or the environment. And then progression, the tumor becomes more aggressive and cells mutate even further. And then it metastasizes. Cancer spreads to other body sites. Cancer don't just happen overnight. Basically, it's a step-by-step process. Mutation, growth, worsening, and then spreading. Primary and secondary tumors. Primary is identified by the tissue from which it arose. For example, breast cancer starts in the breast tissue. Now, the secondary is where it spreads. Breast cancer that spreads to bone is still called breast cancer, but not bone cancer. It's talking about where it was primarily started. The cancer keeps its name based on where it started, so metastatic lung cancer in the brain is still called lung cancer. Steps of metastasis. So we can break this down like malignant transformation is when the normal cells mutate and become abnormal. The tumor vascularization, where the tumor grows blood vessels, and tumors need oxygen and nutrients. And then 3, blood vessel penetration, the cancer cells break into the bloodstream or the lymphs. And then arrest and invasion, cancer cells, they settle somewhere else and start a new tumor. So metastasis is why patients develop bone pain, brain symptoms like headache and seizures, liver failure, and respiratory symptoms. Cancer classification. The grading is how abnormal the cells look. The higher the grade, the more aggressive. The staging is how far the cancer has spread. So the higher stage, the worse the prognosis. The T and M is the T for tumor size, N for lymph node involvement, and M for metastasis. So grade is what it looks like, and stage is where it is. Cancer etiology and genetic risk. Three main causes are carcinogens, genetics, and immune system weakness. Cancer risk increases when exposure increases mutation, the body can't repair DNA, or immune system fails to destroy abnormal cells. So cancer happens when the DNA damage outweighs the body's ability to repair or destroy the damaged cells. External factors causing cancer. You can break it into categories like chemical carcinogenesis, smoking, asbestos, industrial chemicals would fall under that category. Tobacco is linked to about 30% of cancers. Some physical is the radiation, the UV exposure, chronic irritation like chronic inflammation. Viral is the HPV like cervical cancer, or the Hep B and C, liver cancer. Anything that repeatedly injures cells increases mutation risk. So chronic injury equals chronic repair equals more chances for mistakes, basically. So three big personal risks, immune suppression, aging, and genetics. So why age matters? So, well, basically more lifetime exposure, your DNA repair gets weaker. So as we age, our immune surveillance declines, and that's why cancer rates rise later in life. Genetic testing, and just an important point is that genetic testing does not diagnose cancer. It identifies risk only. And genetic counselor should be involved before and after testing is performed. Genetic testing is kind of like a weather forecast. It tells you the risk of a storm, not whether the storm is happening today or not. Health equity. Access to care and variations in socioeconomic background significantly impact cancer development. Some factors that affect cancer rates is access to screening, early detection, transportation, financial resources. So cancer outcomes are not only biological, they are deeply affected by social determinants of health. Primary prevention. Prevent cancer from happening if at all possible. Avoid carcinogens, of course, stop smoking, lifestyle changes, remove at-risk tissue, chemo prevention, vaccines. Secondary prevention is early detection, screenings, mammograms, and colonoscopy. So know the difference between primary prevention versus secondary prevention. Primary prevents cancer. Secondary finds cancer early. So an example would be primary prevention would be if you had a mole or something like that that needed to be removed, then that would be primary prevention, where it says remove at-risk tissue. So keep that in mind. Cancer affects nearly every system because it consumes energy. It compresses organs, triggers inflammation, causes immune suppression. So some symptoms it affects is immunity and clotting, GI function, like nausea, nerve issues like neuropathy, respiratory cardiac compromise, pain and quality of life decline. Cancer is not just a tumor, it's a whole body disease. So treatments are chosen based on the tumor type, the stage, the spread, and the patient's condition. So some of the main treatments, as we'll see on the slide: surgery, radiation, chemo, immunotherapy. There's a immunotherapy drug now called Keytruda that's very popular, that's being used a lot. Photodynamic therapy and hormone therapy. Surgery as cancer treatment. Remove tissue before cancer occurs. If someone has a high risk of breast cancer in their family, now sometimes people will decide to remove the breast before cancer ever occurs. Diagnostic is biopsies. Curative would be like remove the entire tumor. Debulking is remove as much as possible to improve the chemoradiation response. Palliative relieves symptoms. Restorative is like reconstruction. So surgery is not always curative. Sometimes surgery is just done to improve comfort and function. Radiation therapy uses high energy radiation to kill cancer cells. It's usually given in divided doses over a set time. Some delivery methods are external beam, which is the outside radiation, and then the brachytherapy is the internal radiation therapy. It's local. Side effects occur mostly where that radiation is being delivered. And radiation is a targeted burn at the cellular level. It destroys the DNA so the cancer cells can't replicate. Side effects to radiation that are common is fatigue, skin burns, altered taste, bone marrow suppression. Some nursing considerations is we teach them to protect their skin, avoid harsh soap, not to use lotion unless the provider approves. Radiation side effects are localized, so if the chest is treated, then you'll see skin and lung irritation, not the whole body. So it's usually, you'll see the irritation where the skin's being treated. It refers to the use of chemotherapy or immunotherapy drugs. It can be used alone, before or after treatment, or in a combination. So the neoadjuvant chemotherapy is used to shrink tumor before surgery or radiation, and the adjuvant chemotherapy is used to kill remaining cancer cells following surgery or radiation. So the neoadjuvant shrinks before, adjuvant cleans up after. Combination chemotherapy is using more than one drug for the treatment, so different mechanisms of action work together to impact cell division. The cancer cells mutate quickly, and using multiple drugs prevents resistance. And drugs hit different part of the cell division. It's kind of like sometimes when people take two different antibiotics. One may be treating one thing and one another. Chemotherapy drugs, they come in these categories of anti-metabolites. Methotrexate falls under that one. That's a more common chemo drug. Anti-tumor antibiotics, antibiotics, alkylating agents, and the T inhibitors. Issues, talking about dosing. Dosing schedules are real important because the cycles will allow the recovery. Along with scheduling, and there's the different ways of administration. Extravasation, you'll want to know that word. Monitor blood return at the access site during infusion at regular intervals, especially if they're getting peripheral chemo through a peripheral IV. You want to assess that frequently. Stop an infusion immediately if there's any burning, pain, or swelling. That's important to know. Oral chemo can be just as toxic, so it requires safe handling as well. Oral chemo is not safe for chemo. It's the same poison, it's just swallowed instead of infused. So here's a picture of extravasation where chemo drug damaged the skin. It will destroy the tissue. Some signs: if a patient complains of pain, swelling, or burning, or you see redness or lack of blood return, you want to stop the infusion. Do not remove the IV until the antidote plan, and notify the provider and elevate the limb. Extravasation is a nursing emergency, and this is one of the few times you stop an infusion immediately, so be sure you know that. Handling safety, gloves, gown, and proper PPE. Remember that oral anti-cancer drugs are just as toxic to the patient taking the drug and to the person handling the drug as are the IV chemotherapy agents, so be careful with handling both. Chemo can be absorbed through the skin. So you protect the patient, but you also need to protect yourself. Side effects to chemo. Common ones is neutropenia, thrombocytopenia, alopecia, mucositis, skin changes, and anxiety. The CTCAE scale is a standardized system used in oncology to grade the severity of side effects. So the most dangerous chemo side effect is not hair loss, it's infection from neutropenia. Bone marrow suppression is very critical. Why? Because bone marrow makes white blood cells, which is infection prevention. The bone marrow makes red blood cells, which is oxygen delivery, and the bone marrow makes platelets for clotting. So when the marrow suppression, it can cause neutropenia, which is an infection risk, anemia, which is going to cause fatigue and oxygen issues, and then thrombocytopenia is a bleeding risk. So we're going to teach our patients that's getting chemo proper hand washing, report a fever immediately, mouth care, avoid injury, because if white blood cells drop, then the patient has no arming. If the platelets drop, they can bleed out, and if the red blood cells drop, they can't function. Chemo-induced nausea and vomiting can occur at any time. Acute is the most common. So treatments would be like antiemetics like Zofran, or small frequent meals, avoid greasy food, and stay hydrated, because chemo nausea isn't like a stomach bug. It's like a chemical stimulation of the vomiting center in the brain. Mucositis, that's that painful mouth sores. Some treatment for that would be ice water, ice chips, frequent mouth care, assess their oral cavity, avoid any kind of alcohol-based mouthwash, and use a soft toothbrush. Mucositis happens because chemo kills the cells that normally regenerate quickly in the mouth. Alopecia. Hair follicles are fast growing, and so chemo kills them. So we want to teach our patients to prepare emotionally. They may select a wig before they start to lose their hair. They want to protect their scalp from sun or cold. Hair loss is not dangerous medically, but emotionally it's huge. So we want to treat this as a real loss with our patients. Changes in cognitive function. These patients get what we call chemo brain, and that's reduced ability to concentrate. They have memory loss. They have difficulty learning new information. And so we need to support our patients, provide resources for them, and just give them the moral support that they need. The peripheral neuropathy, that's chemo-induced. It's loss of sensory perception. We want to teach them injury prevention by all means, because they're going to have numbness, tingling, burning, weakness, and nerve damage, possible nerve damage. So we want to focus on fall prevention, injury prevention, and they may need an OT consult. Neuropathy can make patients lose balance and burn themselves without realizing it. So that's an important concept. Immunotherapy uses the body's own defense system to attack foreign cells. Immunotherapy boosts the immune response. Immunotherapy can make the immune system aggressive, and it may attack cancer, and it also attacks normal organs. A common immunotherapy drug now is called Keytruda. Monoclonal antibodies combines actions from immunotherapy and targeted therapy. Assess for infusion reactions, especially in the first 30 minutes to 2 hours of initiation. Some symptoms of reaction are fever, chills, hypotension, bronchospasm, shortness of breath, and rash. Pre-medication, reduce the risk. Targeted therapy acts directly on cancerous cell. Each patient's cancer cells are evaluated to determine whether the cells have a specific pathway to be affected by targeted therapy. So not every patient qualifies for this. The tumor testing is required. Endocrine therapy, some tumors grow in response to hormones. Example would be breast or prostate. Therapy blocks hormones or hormone receptors. Side effects do depend on the drug. So if a tumor is hormone fed, endocrine therapy starves it. Colony stimulating factors as supportive therapy, used as supportive therapy during chemotherapy by enhancing recovery of bone marrow function after treatment-induced myelosuppression. Most common side effect is bone pain. It does stimulate white blood cell production. These drugs force the bone marrow to work harder, which is why patients feel the bone pain. Oncologic emergencies, these are the kill you fast kind of emergencies. Sepsis, DIC, SIADH, spinal cord compression, hypercalcemia, CVC syndrome, and tumor lysis syndrome. If your patient has cancer, always ask what complication could kill them. Look at this photo, appearance of CVC syndrome. It's compression of the superior vena cava. Some symptoms that you will see: facial swelling, neck vein distension, upper extremity edema, dyspnea, and headache. So our priority for this patient is always going to be airway and breathing. Elevate the head of the bed. Radiation or chemo may be ordered to shrink tumor. So this is a circulation problem that quickly becomes a breathing problem. So the head swelling can signal impending airway compromise. Very dangerous. Survivorship. Survivors usually have long-term effects like fatigue, depression, fear of the reoccurrence. Most of them do. Neuropathy, sometimes they experience organ damage. So we want to make sure that we have followed up with these patients, try to encourage them to come back for follow-up visits and screenings, and just a lot of lifestyle education to prevent reoccurrence of the cancer. Survivorship doesn't mean the journey's over, because many patients live with chronic side effects and emotional trauma after cancer. I am going to allow you guys to do your case study from this slide on, and we can discuss them in class. Thank you.